Dear colleagues, your attention please. So the after-lunch session is always more serious than the pre-lunch session, but I think that we actually had more worries that we would have some medical casualties here, but the topics that we're about to discuss throughout this session are very topical. It is the financing and drug provision. These are the resources, the absence of which I suppose would disallow any medical organization to offer its medical and healthcare services. The problems pertaining to the issue of funding and financing in various countries vary in their solutions. Different models are applied. The efficiency and effectiveness of different models is different. And such discussions as the one we're having now are quite necessary to define the right steps in our reforms. And using the example of our country, I'd like to tell you that this process of healthcare funding reforms took place and it was very difficult indeed. Before I begin telling you about our country, I would like to introduce the co-moderator, Mayak Aftaradze, Regional Technical Advisor of the Global Mechanism for Drug Provision. And I am Marat Khalif, Chairman of the Health Insurance Fund in the Kyrgyz Republic. Our presenters, I will announce our presenters right before they begin their presentations, and as you have already mentioned, all the presentations are linked to financing and drug provision. Now, coming back to healthcare financing reforms in the Kyrgyz Republic, I could say that we were also forced to overcome a number of barriers, and currently the system has led to a situation where, of course, it's not only the changes of the healthcare financing system, but also other comprehensive approaches that have, in their totality, led to a situation where many resources have been effectively redistributed. Let's take an example of a few parameters. Hospital admission rate before the introduction of the new financing model was approximately 14.5 thousand per year, whereas next year after the introduction of the new model, the hospitalization rate went down by 1,000 admissions per year, and now about 5 years have passed, and the hospital admission rate has gone down twofold over these years. So you can imagine from 14.5 to 15,000 hospital admissions per year, we have reached a level of 8,000 hospital admissions. The resources that used to be channeled towards the 14.5, 15,000 patients were now concentrated on the patients that are now enjoying the TB services. And at the previous session, you discussed this, and Nura Sultanovna presented the outpatient model that we have implemented. And these resources of the hospital sector, we managed to channel to primary healthcare. This is one of the complicated tasks, one of the difficult tasks, but we have done it. And we are hopeful that using the example of the TB service, we can also move other services not related to TB, such as cardiovascular diseases, mother and child health. I hope that we will be able to introduce the same mechanisms to improve the efficiency of primary health care. That means that we will reprogram resources from the hospital sector to primary care. Quite naturally, there are a lot of difficulties, and these difficulties will persist. They will not go away. The process of optimization of the TB infrastructure as such is ongoing. Sometimes we have such questions and issues that may not be directly related to the treatment of patients, including what do we do with the 4 hectares of land becoming available and vacant after the hospital is closed. No one can answer this question now. There are a lot of accusations addressed at the reformers immediately, or we now start having questions about the buildings and about the infrastructure that is being changed, and it has a very painful impact on the reformers that are not looking at such residual facilities and residual structures that have to remain after the reforms. So, dear colleagues, I suggest that we proceed to our presenters, and I would like to give the floor to Aram Manukyan, Deputy Director of the Armenian National TB Center, who will tell us about the process of transition from global fund to state funding in Armenia. Please, you have the floor. Thank you very much for the floor. In this presentation, I will tell you about the evaluation of the readiness for transition that has taken place in the Republic of Armenia. For most of the countries, the representatives of which have gathered here in this audience, a necessary precondition for the current grant of the Global Fund was to evaluate the readiness and preparedness for the transition, preparing the transition plan and the actual transition process execution before the end of the current grants of the Global Fund. Now, what is this transition? In fact, it is the mechanism by which a country can move to full state financing in all the state programs that are currently being funded by the Global Fund, with the condition of ensuring sustainability of these programs and the maintenance of the results that the countries have been able to accomplish to date. Under sustainability, different countries mean different things. In our case, sustainability is the solidification of the results attained and the expansion of the coverage of the population with healthcare services, if needed, if so the epidemiological content of the disease dictates. The process started in 2016 with the formation of a working group under the Ministry of Health of the Republic of Armenia that included representatives of different national agencies, including NGOs, public entities, international organizations. And at the end of 2016, they started to collect data on the tool for the assessment of the readiness for transition, which was presented through joint efforts with the Global Fund. And I think that that tool was developed by Curatio, that's a Georgian organization. It included 24 indicators that one had to gather the data for to assess whether the country was ready for transition. In reality, these indicators were the areas necessary for program execution. So they were split into external and internal indicators. External are the ones that are not related to state programs, including TB and HIV, for instance, and others were connected and linked to the programs under implementation. External conditions mostly included political readiness of the country, situation in the country, and the economic environment that have a direct impact on the ability of the country to engage in programs or in commitments. Internal environment included financial and human resources, existing information systems that ensure monitoring and reporting of the program, service delivery system, organizational capacity. All this was taken into account when assessing the readiness of the country for transition. For many countries, most of the above indicators may be addressed at the legislation level or by introducing mechanisms or by changing some laws and regulations. As far as human resources, accountability, and reporting are concerned, for instance. But there are certain issues that are not directly related to this, and they cause greater concern. That's mostly economic and financial situation. And if you take a look at the chronology, at the timeline of the Global Fund, the grants in the Republic of Armenia that you can see on this slide, you will see that we've been having these grants since 2003, and a lot of money was transferred to the Republic of Armenia for the purposes of these grants. TB grants started in 2006, and they are still ongoing. But from this slide, you can see that we have between 2.5 to 3-point-something million that we spent from the Global Fund resources for the execution of these programs since 2006. But the grant that is intended for 2019 to 2021 will be the last one. That means that we will need to have completed this process of transition by 2021. Now, the funding here is in dram, in the national currency of Armenia, but you can compare it to the overall financing, and that's about 3.5 million per year. This is how much we get from the Global Fund, and the government matches that amount. Overall, about 48% of the TB grant is financed by the state, and 52% of this budget is funded by the Global Fund. But previously, we also had some USAID projects that have provided this funding. However, an analysis of actual and planned figures shows the following. We were looking at the situation at the time of analysis. It looked okay, but when we compared plan versus actual, we could see that the overall budget of the Ministry of Health, let me proceed to the next slide. So you can see an increase of the TB budget on an annual basis. This happened when the assessment was underway, and in the last year, approximately 500,000 was the increase compared to 2012. So that's the increased financing by about $500,000. But take a look at the last but one line. The total budget of the healthcare ministry does not really change that much. Outpatient TB assistance also doesn't change, although the reforms that we have executed imply that the amounts to be taken out of the hospital sector, that's the third line on this slide, would be channeled to outpatient networks, to the development of the outpatient network. But the overall analysis of all these indicators has shown that we have a moderate to high risk of transition unless we undertake certain actions and exercises that are included in the plan. Unfortunately, the plan was only ready before we had to leave for this conference, so we have not had the time to prepare the presentation of the plan. But out of the 24 indicators, 8 are high risk, 11 moderate risk, and only 5 were low risk for transition. In reality, the preparation of this transition stage started a long time ago. We realized that sooner or later we would have to say goodbye to the money provided by the Global Fund, and this is why we started the reforms. We started creating favorable conditions for this transition to public financing. What did that include? That started back in 2014. That included financial reforms, and I will tell you a bit later about those. There was also a transition from hospital to outpatient care, and there were structural reforms that were pursued depending on the epidemiological situation in the country and depending on the needs that the country had at the moment. So we are considering this TB system and the organization of this entire arrangement not as a structure that cannot change, but rather as a structure that can be easily changed along with the needs of the country. Previously, prior to 2014, the country had inpatient services financing on the basis of bed days, and outpatient services were financed back on the basis of capitation, but many resources had to be allocated. That was not efficient. With the introduction of new financing mechanisms, the approach to patient hospitalization was changed. The number of admissions went down. The number of persons that were not diagnosed with TB but hospitalized also went down. Average length of stay went down, bed occupancy rate went down. All that led to certain savings. To certain savings of resources, which were then channeled to the outpatient network. So these savings and the situation after the reforms were such that 78% of the entire budget was spent on hospitals and only 22% was spent on outpatient treatment. Increased costs per capita for TB patients at the outpatient level was also strengthened. Overall, if you take a look at this diagram, you will see what this has led to. I can say that the redistribution of resources between the outpatient and the hospital levels has not really made us so happy, and we started to think about further reforms. At the first stage of our reforms, this led to the suspension of financial incentives for hospitalization, because previously the hospital system was hospitalizing more people to cover their costs. Now this is not happening, because you have fixed financing for the maintenance of the hospital, for salaries, for utilities, and then the money for the patient only is spent on the coverage of meals, drugs in the hospital. So whether the patient is in the hospital or not, it does not influence the salaries of the doctors or the abilities of a given institution to cover their prime costs. For the outpatient network, previously it was based on the number of patients, so that patients registered or enrolled with the healthcare institution. This did not create any financial incentives. So we decided to introduce performance-based payment as a means of incentivizing a good performance of all these activities. If you take a look at the entire structure in general that we had before 2014, you will see that we had 9 hospitals, 9 laboratories, 448 hospital beds across the Republic, 72 offices, 29 in the city of Yerevan, and 6 TB labs also in Yerevan, 51 in the regions, and 18 labs also in the regions. So this was quite a burdensome structure, but with the reduction of the prevalence and incidence rates, with some positive epidemiological changes, we now have the following structure. The number of beds went down, the number of hospitals down from 9 to 6, number of labs also went down, number of TB cabinets both in Yerevan and in the regions also went down. And at the moment, we are involved in this third stage of the optimization agenda that starts with the capital city, and it will then continue to be replicated in the larger cities of the region. So the figures that you can see now will go down further, and the structure itself will also change. If you take a look at Yerevan, at the Republican level, you will see that we used to have 48 TB beds in the TB dispensary of Yerevan. That's inpatient service, and we also had outpatient service where we had TB cabinets or offices and laboratories. Now, this is the way it used to look. This is the way it used to look. That means that in pretty much all polyclinics we would have TB cabinets where infected people would come to take their drugs. We had laboratories in major polyclinics. So personnel was actually located in all polyclinics in these TB units. Now this is going to change. We decided that instead of TB cabinets, we will have the BOT points or units where we will either have mid-level healthcare professionals, no physicians, no doctors, because patients usually come there to simply take their medicine. So you will either have mid-level healthcare professionals, or this responsibility will be given to family doctors or the personnel that works with the family physicians. That means that the polyclinics will not have doctors in the Yerevan dispensary. It will be transformed into the pulmonology and TB care center. All the hospitals will move there. The main laboratory will move there. Across the city, we have very good transportation of biomaterials, including sputum, for analysis. Thanks to that, we will develop a schedule in accordance with which all the specimens will be delivered to the laboratory for analysis. And on a need basis, the hospitals will provide consultations to these DOT units, or maybe they will rotate and patrol them depending on the workload. What is this going to lead to, in our opinion? This will lead to the introduction of a new model of an outpatient service in the city. It will lead to the redesigning of the center. Currently, the center does not have high workload, so the workload of the outpatient part of the center is going to grow. The number of hospital beds is going to go down. 4 inpatient units will close in the northern and southern regions of the country because the workload of these hospitals is extremely low, and the funding for the outpatient service will increase. This is what we intended from the beginning, but we can see that as far as the allotments from the Ministry of Health are concerned, this is not forthcoming because their budget is not growing. And I think that the overall budget for the TB service will be split 60-40 between the hospital and the outpatient services. This will lead to the strengthening of the outpatient TB services as such, and this will lead to significant savings of resources that later on, after the global funds grants are depleted, will be somehow covered thanks to the state and public resources. In principle, that's it, and thank you for your attention. Questions later, I suppose, right, or now? Thank you, Aram. We will have some questions, but I think at the panel discussion. So thank you for the interesting presentation, very interesting indeed, and major strides have been taken in the optimization agenda. I think that as far as the procedures and optimization steps are concerned, we have a lot of strong-willed decisions, if I can put it that way, and I think that our organizers should also try to learn some lessons from this in relation to these very serious interventions. So, dear colleagues, next presentation. I would like to give the floor to Barbara Roth, a pharmaceutical expert from the MSF Pharmaceutical Office, the XDR drugs, access, registration and procurement strategies. Czy jest ta prezentacja? Nie, nie.
Hello, everyone. First of all, I wanted to say thank you. It's my first participation to this TB symposium, and not only I enjoyed the presentation that we had for the last 2 days, but I find it a great opportunity to actually meet so many of the actors in the region and have this kind of privileged discussion. So a big thank you for the organization. I've been asked to present, to do a presentation on access update, registration and procurement of strategy. As you will see, and I need maybe to apologize a little bit about that, as the people who already participated last year will find a lot of similarities to last year's presentation. And the reason is that I will present some of the progress that were made since last year. We still have a lot of concern and we see still a lot of opportunities in terms of work to be done in registration and how to better use the tools that we have available. Also, it is even more relevant in this context of the global fund transitioning, as we need to continue to make sure that we have access to quality assured medicine at the most available and affordable price. So let's start with the access to bedaquiline. I will not go through some of the generic information that you're probably all aware of. I think what is interesting to mention is if I compare with last year the bedaquiline was registered in 12 countries. Now they are registered in 21 countries. Just wondering if the translation is the same. I'm not sure. I think the numbers are not matching between the Russian and the, yeah. So in this case, you need to refer to the English translation. Sorry about that. So especially in the region, the product have been registered in Uzbekistan, also in Russia. There are submissions soon to be due in Ukraine, and the registration has been unsuccessful in a few other countries due to the absence of phase 3 data. As stressed yesterday by our colleague from WHO, there has been numerous WHO guidelines which have supported the access to bedaquiline. But we still notice that this needs to be translated into national guidelines. According to the out-of-step report from 2017, the bedaquiline was included in only 79% of the country that were surveyed. The good news was that in May already, May 2015, the bedaquiline was added to the essential medicine list of the WHO, but it still needs further work to be translated into the national essential medicine list. I think it is interesting to note that according to the latest data we have from November 2017, a 6-month course is still at a price of more than $1,800 in the Russian Federation, and you have a different type of price depending on the low or medium or high income countries. Of course, at the moment we are fortunate to have access to the bedaquiline through the USAID and Janssen donation, which is channeled through the GDF. And it is really welcome to see that there has been such an increase in the number of courses that have been ordered and delivered to the various countries. Looking now at the delamanid, we are all waiting for the EMA to take into account the phase 3 clinical trial result, and this should happen in the course of this year. It is a product that has been registered in much less country than bedaquiline. And also it seems that the prioritization of those countries is maybe not matching actually where the highest needs are. And further work needs to be done, and hopefully also with the partnership that Otsuka set up with R-Farm, this is something that will develop in the good way in this region. Maybe here was to say that there is, since February 2016, delamanid is available through the GDF at a price of $1,700 for a 6-month course. So now I will shift from the new drugs to the repurposed medicines, starting with linezolid. The innovator is Pfizer, but we are lucky to have a couple of quality assured generic options available on the market. And this is also thanks to the fact that there are secondary patents in some countries, but still we don't see that as an important blockage factor to access to generic companies. Unfortunately, there is no TB indication, and in some of the countries, this is an issue to include them into clinical guidelines, and also to then later on procure them. Something you probably all know about it. It was upgraded as a category C in the MDR-TB WHO guidelines, and this also needs to be further translated into the national guidelines. I think it is interesting also to notice, and this was, I think, already presented last year, is following the big negotiation done by the GDF in 2016, the price of the linezolid really dropped drastically. At the time, it was 75%. And these, to give you an example of the cost, we went from more than $3,000 per treatment course, thinking about a 20-month treatment course, to a little bit more than $800. So this was a big achievement. However, we still see that there is sometimes an issue with the price in certain countries. One of the countries that were flagged to us was the one in Belarus, the situation of Belarus, where the generic is actually, the price of the linezolid is very high. Maybe for your information, and we were talking a bit about pediatric DRTB, I think it's interesting to know that there is a new formulation that we are all expecting to be accessible very soon with a generic company, MacLeod's, who has developed it. And we are hoping that it will go through the Global Fund expert review panel in the next couple of months. Now, looking at the clofazimine, we are still in a monopoly situation. It is only available from Novartis. And we know that there are a couple of generic companies that are working on it. Unfortunately, it has been delayed, and nothing is really happening at the moment. And we have unclarity about the timeline to have those generic formulation available. Again, no TB indication, which has been a problem in certain countries, but Novartis managed to get a commitment from the USA FDA to fast-track the assessment of some retrospective data that Novartis will compile in order to submit and to endorse a TB indication. In terms of price, at the moment, and whatever the country is, Novartis had only one price, and it is $597 per treatment for 20 months. Going to imipenem-cilastatin, the innovator is MSD, but again, we have many generic options or alternative options. There is no TB indication as well, and so it is considered as a repurposed medicine for DRTB. The best available price at the moment through the GDF is from Panpharma at more than $3,000 per treatment for an average duration of 8 months. There's a lot of doctors here. You all know about the medical hassle or to give those medicines. And we are all dreaming about something that would be much practical to administer to patients. However, we are a little bit in a strange situation because we don't know how much longer this product will remain of any interest in the treatment regimen, in the TB treatment regimen. So it's a little bit also difficult to position ourselves and negotiate further with manufacturer. So if we look at challenges in access, what we have seen and what is helping us is when WHO guidelines are issues on how to dispense them, how to use them. The listing of those medicine on the WHO essential medicine list, because it paved the way to national program to also push for them to be listed at their level, and obviously to have quality assured sources at the international level. But we still remain with many blocking factors. The delay in updating the national TB program, the lack of TB indication that needs to be reversed, and the delay in national registration or lack of importation waivers. Obviously, the cost is a challenge. And here I wanted to show you this slide. It's looking at the cost per patient per month. The medicines are organized from the lowest price or the lowest cost to the highest cost to the right. So we listed here all the current price available. It's based on the latest GDF available prices. So you can see that linezolid, for example, costs $42 per patient per month. And we go up to the bedaquiline outside the donation in a middle-income country at around $500 per patient per month. Some of them, we listed the manufacturers when there's only one option. You can see here that we indicated 4 different prices of bedaquiline. The first one is hypothetical, is the one that we are wishing for. The day we will have a generic, this is the price that we are considering at the moment. Then for low-income country, this is the price that Janssen is giving at the moment, so $150 per patient and per month. And the last column here, sorry, I missed the price given by Farm Standard for the Russian Federation. So again, it's price per patient per month. At the bottom of each column, you will see some information which are linked to a recently published article by Gautam and colleagues, which are giving some information about an estimated generic price. So you will see it's quite low, but we have noticed that if we consider the moxifloxacin, we used to have access to a very expensive moxifloxacin, and now we are down to $9 per patient per month, which is actually not too far from what the Gautam had estimated. So we believe that it might not be our immediate success, but we should go in that direction and negotiate much further with the manufacturer. I think it's also really worrisome to see imipenem here being among the most expensive repurposed medicine that we have to consider. And I think another point that we wanted to make is we always talk about 6 months treatment of delamide and bedaquiline, but as we were discussing earlier this morning, we are not talking about 6 months. Most of the time, we're talking about a longer period of time for treatment. So if we accumulate or if we add up all those prices, the cost of MDR, XDR patient is actually extremely high. How can we do better in terms of price? TB has always been complicated because it's a small market, and the only way forward has been to pool actually all the needs. And the GDF, the Global Drug Facility, is a good example of a tool that has managed, or an institution that has managed to negotiate quite well prices with the manufacturers. I think as an example, I wanted to show you the comparison that was done between the price in 2011 and in 2016 in US dollar. It was on the left, it is considering the highest price regimen medicines, and to the right, the lowest price regimen medicine. So if I take the highest, we managed to go down from $9,000 US to a little bit less than $4,000 in over 5 years. I think it's also interesting maybe here to say that the shorter regimen, according to the latest price shared by the Global Drug Facility, is at around $600 to $800. How can we do better on regulatory components? This you all know because we are deep into it with bedaquiline and delamide, but I think we should not forget it for any upcoming new drugs. And maybe we should try to anticipate and not reproduce the same mistake. Maybe be more proactive on compassionate use of medicine. Even expanded access, because sometimes it makes it much faster to give access to those new drugs to the patient who really need them. The import waiver is a great option, but it should not be a sustainable option, and we should work towards a more sustainable system. And then obviously we have also the temporary access under a national research program or framework that works in many countries. Now moving to the regulatory component, and especially the expedited registration. We are learning every day about some initiatives that exist in countries, and we are very grateful for the information shared by a national TB program or the actors in those countries. One of those examples was in Ukraine, for example. There is this mutual recognition between regulatory authority, which allowed the clofazimine to be actually registered in a very short time. And this option should be promoted. It takes the benefit of an assessment that has already been done, and there is a commitment with a certain timeline to register those medicines. There is also this regional harmonization regulatory framework. One of them is in the Eurasian region. It is something that will be explored by AFAM, or is actually already starting exploring it, and will help getting access to the delamanid hopefully faster in the countries that are part of this regulatory framework, being Armenia, Belarus, Kazakhstan, Kyrgyzstan, and obviously the Russian Federation. Another important collaborative approach is the WHO, is the one that was started by the WHO, which is called in short the CRP, Collaborative Registration Procedure. The various steps, I mean, the principle is actually a product that has been pre-qualified. It started with pre-qualification product. So a product that has been pre-qualified has been assessed by the WHO pre-qualification program. A dossier and conclusion of the assessment is available. So any country who's interested to have access to it can be part of this collaborative approach, make a request, and the WHO will facilitate the coordination and the communication between the manufacturer and the authority who wants to register it. The fact that they are sharing, that the WHO is sharing their conclusion, can help actually an authority to also make a decision or take a decision faster. For this WHO pre-qualification, for this WHO collaborative registration procedure for pre-qualified product, 33 countries have already joined the process, and it led to many products being registered all around the world. If I'm not mistaken, from the region here, we have Armenia, Georgia, Kyrgyzstan, and Ukraine that are part of this collaborative procedure. Recently, and especially with bedaquiline, they had a pilot project promoting or looking at SRA, so strictly regulated authority registered product, like clofazimine. It could apply for TB, like clofazimine or what else? Linezolid from Pfizer, etc. Any of those products could be considered in that procedure, and they duplicated a little bit the same procedure for those products. But it's a procedure that is still in a pilot, and we are hoping that it will become more used or of use for all the drug regulatory authority. I started looking a little bit more at all the drugs that were registered, and some work has been done in the region, for example, for those drug-sensitive TB, isoniazid, pyrazinamide, I saw ethambutol. But actually, at the moment, there's nothing for the DRTB medicines. And this is probably an area where we need to work a little bit more. One aspect that I didn't mention is that a survey was done in 2014 that showed that this procedure actually led to registration of product within 94 days as on average. So quite fast. Sorry, I went too fast. So in this context of the Global Fund co-financing and transition plan, there is a need to actually, for country to better anticipate the way those drugs can be accessed in the long term. We know that they need to be registered so that they can be considered in national tender. And also how to make sure now that all those quality assured medicine that are being used to treat the patient continue to be available in the long term. So we need to explore further ways to keep maybe the GDF or any other entity as a bidder in national tender. Another way is to anticipate local registration, as I was saying earlier, how we can further promote this work now in anticipation of the transition in the future. Thank you very much.
Thank you, Barbara. I guess audience have a lot of questions, but I think questions will be reviewed later because we're somewhat behind the schedule. This is quite interesting. There are a lot of issues with prices, and prices has always been an issue, but we see positive dynamics. Of course, there are issues with registration, with generics, and currently used drugs. My dear colleagues, I would like to give a floor to Serim Akhmetov, the advisor of USAID on TB, the global TB program, on the status of execution and the progress. Serim, floor is
Спасибо
yours.
большое. Good afternoon, everyone. Let me first start with the customary thanks to the organizers of this wonderful meeting, conference, and of course the host government, the National TB Program of Kyrgyzstan, as well as the Ministry of Health. And not least, not forget our interpreters and translators in the back that I think have the hardest job in this room. They have been having the hardest job in this room in the last couple of days. So I'll try to go as fast as I could so we can catch up on time. Oh, music? Okay, спасибо. When I was asked to present today the topic, I thought the topic about talking about USAID funding, I could have replied in an email and could have taken 2 sentences and could have saved me a long trip to come here. But so if, with your permission, I'll digress a little bit from the topic to actually go into the question, what is behind the USAID funding, and provide an overview of what USAID does and what is the rationale for our funding decisions from a global perspective. And of course, starting from a global perspective, I think it's always good for us to remind ourselves that TB remains the biggest killer of humanity, and it has been the biggest killer of humanity for a long time, as you can see from this picture. So another thing to remind ourselves is that TB is not a uniform epidemic. We're actually experiencing 3 different epidemics across the world currently. One being the drug-susceptible TB, and as you can see from this slide, the biggest burden of that drug susceptibility TB is on the Asia continent. That's the pie chart in the middle. What is very relevant for us, of course, is the pie chart on your right when we look at the burden of MDR-TB, and you can see the slice that is in purple. That's the region of Central Asia and Eastern Europe, and you can see the disproportionate burden of MDR-TB in our region, which is, of course, why we're also here today. And then if you go to all the way to your left, when we talk about TB-HIV, it's the region of Africa that is most impacted by that co-infection. But it's always good for us to remind us that when we're dealing with TB, we're dealing with also very differentiated epidemic. So the biggest kind of globally for us in TB, the biggest question currently remains to find these missing cases. Where are the 4.1 million cases that we're estimating to be out there in the world that are currently either not reported through the TB programs or they're truly not detected. And you can see the top countries with India, Indonesia, Nigeria. I need to check my eyeglasses, but South Africa, Pakistan, and Bangladesh make the majority of those missing cases. The good news for us, if you guys hopefully have a better eyesight than I, but you can see that the bottom countries, those are the countries in our region, and Kyrgyzstan is at the bottom, which in this case is actually a very, very good news, indicating that a very small proportion of the estimated cases are not being reported through the TB program. Regarding drug-resistant TB, the cartograph on your left, if we try to present the world map in terms of the burden of MDR-TB, you see how that would look like on the map of the world. And in our region, although this map is not the best map to present that, but you can see that our region is disproportionately bigger when it comes to the burden of MDR-TB. In terms of all of these things that are listed on the left side, we were discussing in the last couple of days. But the challenges that do remain for us in terms of facing MDR-TB. And important thing is we're estimating that by 2050, about 75 million people will lose their lives to MDR-TB if we do not accelerate our response. And in terms of the economic burden, the estimates are that 17 trillion US dollars will be lost due to this, due to MDR-TB. This is very quickly just, these are data from the US and what it costs to treat a drug-susceptible TB, to treat an MDR-TB, and to treat XDR-TB. And as you can see, the differences in the costs of treatment for these three different types of strains of TB are quite different. And you can also see the effect that has on and the different social categories and the different laws in terms of what it means for patients. I mean, this was done, of course, in the U.S., but the cost, overall cost, not only in terms of economics, but also in terms of quality of life for our patients. So where does USAID come into this picture? We do have, of course, a strategy. Our strategy runs through 2019. Currently, we have some specific indicators and specific objectives that we are responsible for. The box in the red, that's the addition of the so-called National Action Plan to combat MDR-TB. That development came in the middle of our strategy, but because of that National Action Plan to combat MDR-TB, we added 200,000 additional MDR-TB cases as a target for us to initiate on treatment, in addition to the 360,000 MDR-TB cases that we originally had in our national strategic plan. So going back to this, no need to you can see for yourselves that these are very, very ambitious targets. And in terms of how that aligns with the funding that we received through the U.S. Congress, funding, of course, is never never enough. But this is just the trend and the trajectory of since the start of the TB program at USAID in 1998. You can see the funding levels have gone from less than $10 million to about $245 million that we received in 2017. And for those of you who follow U.S. politics, you're aware that 2017 was a very, very challenging year overall for government budgets and government funding in the U.S., but despite that, we did receive a $5 million increase in our TB budget. But $245 million is what we received last year for the TB program. So this is specifically the funding that goes through USAID and does not reflect the funding that some TB funding that also comes through other U.S. agencies and sister programs. So in terms of how the funding gets distributed between the different activities that we have, I mean, clearly the team, although at USAID we're called the TB division, I was in the military division, had different, size and numbers. Our TB division at USAID is only about 20 people, so we like to call ourselves more like a TB team. And we are quite effective in terms of how this most of the funding that we receive through Congress, most of that funding actually comes to the countries that we support, and very little of it, less than 9%, is left for operations and management. Very, very briefly, the importance of the National Action Plan to combat MDR-TB. Only 10 countries in the world are included in this plan, but let me start with the caveat that no additional funding is associated with this National Action Plan for MDR-TB. The idea was to use our existing funds and see how we can put together activities to address the main objectives of the plan, which to a large extent for the USAID part remain on detecting MDR-TB cases as well as initiating them on treatment. But the plan also has a US-specific component that the Centers for Disease Control and Prevention are responsible for. But this is very important. The two countries currently that are included in the National Action Plan in the region are Ukraine and Kazakhstan, but as I said, the main objectives and goals of the National Action Plan apply widely across the other countries in the region that we work in and that we support. Very briefly, just to make sure that we do, as I mentioned also, USAID is the lead agency within the United States government for international tuberculosis efforts. We do work with other agencies as well as other programs within the U.S. government to advance the TB agenda. The main one of them, of course, is the presidential initiative for AIDS, PEPFAR, or OGAC, through which we do receive approximately between $130 to $140 million per year, specifically for TB, HIV-related activities. CDC also has a role in terms of surveillance, laboratory strengthening, as well as research-related activities, as well as the National Institutes of Health that do provide quite a lot of funds, and do they have activities for TB-related research, and also the Department of Defense has some funds. Where do we work? As I said, the footprint is quite large for the amount of funding that we do receive, but the two colors on the slide represent the two categories of countries basically that we have. The ones in the darker whatever that's green. In the darker green are the countries that we do provide direct bilateral support. For example, like in Kyrgyzstan, we do have projects and programs that they receive direct funding. The countries that are in the actually the other way around, sorry. The countries in the light green are direct bilateral funding countries, and the countries in the dark green are the countries that we do have funds to work on, mainly on implementation of global fund activities and provision of broader technical support. In terms of some of the achievements, as you can see, we have been successful in reducing both mortality and incidence in the countries that we have been working in. And also in terms of the treatment success rate, that's also one of the major accomplishments of the program. And in 2012, as you all are aware, WHO changed the definitions for completion of treatment, and we're looking at all TB cases, not only the smear positive ones. In terms of MDR TB and where we are with the numbers, mainly for initiation of patients on anti-MDR TB therapy, in that aspect, we also see a nice increase year by year. So in terms of our approach that we provide, it's really the bottom line is we do support the national strategic plans of the countries, really to have this evidence-based programming, introduction and scale up of new tools, technologies and innovative approaches, as well as assisting in implementation of quality and patient-centered programs and a major support to improving data and M&E efforts. Just to draw your attention to the graph on your left, it's important to remember all the both USAID's funding and the USG funding in general, as well as the Global Fund. The orange line in the middle, that reflects actually the domestic funding, and as you can see, the domestic funding is much larger in comparison to the funding for TB that USAID puts and the Global Fund. And it's important for us to remember that the support for TB activities largely still comes from the national sources. Just a couple highlights of specific activities and specific initiatives that we have supported. You're all aware of the donation program. It was mentioned several times, but we also worked with CEFIT to develop a specific agreement on gene expert and scale up of the gene expert technology across the countries that we work in. I cannot take credit for this slide, that reflects to a great extent the work of our GDF colleagues. But in terms of the main message here is that in terms of the products, the number of products that have increased, as you can see on your right side, and the price of those pharmaceutical products has actually decreased, which is also a very good news. I think you saw the slide the first day yesterday during Martin's presentation. In terms of what is it, the cost effectiveness of investing in TB, as it says on the slide, is actually a no-brainer, and you can see how high TB ranks in comparison to some other interventions in order to achieve some very specific development goals. So I'll stop here. I'm sure I bored you enough. But really, once again, thank you very much for your attention, and if there are any questions, we'll be glad to take them.
Yes. Thank you, Savim. A very interesting presentation indeed. And in our country, we're also working very close collaboration with USAID projects. And I would like to take advantage of this opportunity, being the moderator. I would like to extend our appreciation to you for this working atmosphere in our relationship with the USAID projects. We're working on many agendas, not in the project mode when someone comes from the outside and does things for you. No, sometimes there is no line. The line between the national staff member that works in a department or in a division and the specialist that works in the project, this line quite frequently disappears. These people work together, they do things together, and in these organizations, people from the outside do not see any differences between the staff members or the members of the organization. They just think they're one. I think this is a real accomplishment in itself. And thanks to this friendly atmosphere in our interventions, we do have good results. Now I would like to give the floor to Dumitru Latichevsky, Regional Manager of the Global Fund, who will tell us about the Global Fund's view of the transition model. Please, Dumitru. Thank you. I will speak English so that I reduce the number of people that can be making fun of my accent, because, English speakers are the minority.
Savim hopes that he has bored you. Wait for my presentation. But really, thank you for being so gracious and acknowledging both the organizers and the translators, so that I completely subscribe to that. I think the work of the translators is really critical, because they help us get around the situations in which we don't completely understand the language. And I can volunteer to translate from Dolaresque for those in the audience who do not speak this language. And in the jargon of donors, every time you hear sustainability, you should know it means we don't have money for you. And transition means you have to bring money from home. So my presentation is about that. I'm very proud also to work for the Global Fund, because I believe it's one of the more mature and unsentimental organizations on the stage. We're only 13, 14 years old, but by birth, by our framework document, we decided to insert the language of sustainability in our mission. So as we fight with AIDS, TB, and malaria, we committed to attract additional money to make a sustainable and significant contribution to the reduction of infections. So now, understanding the Donoresque, this exactly means that we'll try our best, bring some money to the table, give some time to the programs to deal with the problem, and then leave the stage, and that's a guarantee. Our model was always very simple. It was about raising, spending, and proving results. And together with other partners, but mainly due to the work of those in the audience, the trends are generally very good. And of course, there's a lot of work to be done. But what we see in the trends is also a promise for the Global Fund to disappear at some stage, and probably soon in the future. And that is because the equation of transition is relatively simple. The high burden and the modest means for dealing with that burden guarantee an ascending trend. What we collectively achieved is that the burden went small, the countries grew more and more capable of dealing with the diseases, so we see favorable trends. Which then means that the Global Fund can now focus on preparing the transition, which means exactly you have to bring money from home. And as a policy, and in the next 40 slides, which I will skip, in which the Global Fund describes this approach. But I think the main message here is we continue to reduce the burden and collectively do this, and we count on more resources from domestic sources to be able to transition the Global Fund away from the state. Thank you.
Ресурсы для того, чтобы глобальный фонд мог рано или поздно сойти со сцены. Спасибо. Thank you, Dmitry. Thank you very much for being so concise in your presentation. You know, we have a saying that brevity is the sister of talent. Well, dear colleagues, I would like to give the floor to Maya Kovtaradze, Regional Technical Advisor to the Global Mechanism for Drug Provision. And she will sum up this session, and I think that she will help us moderate the discussion and the Q.
Useful, well-organized and beautiful symposium, and bringing all people who we need to have together to decide for the future and discuss current situation of TB control in the region, and region for us starting from Europe ending to Asia. So first of all, probably we go for questions to presenters, and then we make some kind of wrap-up. Please.
Hi, thank you. Maya, actually my question is for you. Hi, I'm Sharon Ann. It's nice to meet you. My question is, I understand as MSF and GDF, we share some common concerns regarding the Global Fund transition and the co-financing policies when it comes to procurement of drugs, and in particular second-line drugs. So since you're up on the dais, would you mind expanding on those? And then, of course, I'm happy to chip in.
Thank you so much for this question, because anyway, I even have prepared a few slides for that, because that's a great concern of mine, not mine, I mean ours. And before I answer to you, I have a question for Armenia, if you allow. So Armenia is doing well. I mean, the program is really very advanced, and they have uninterrupted supply of quality-assured medicines and diagnostics. From next year, Armenia is transitioning to financing of first line and co-financing of second line. Money is assured, but my question is if there is a plan for procurement for first line.
Лекарств первого ряда. Yes, first-line drugs were supposed to, well, they actually started being procured by the Ministry of Health of the Republic of Armenia. Last year, they tried to purchase them using the Global Fund mechanism. This year, they already called for an international tender. We think the purchase will go through, so the money has been allocated by the ministry. So you're saying there is going to be a national tender, an international tender. Okay, international but locally. Yes, it's going to be a locally announced tender, and everyone who has WHO pre-qualified drugs can apply. So
one of the requirements will be WHO pre-qualification, right? Mm-hmm. Thank you so much. So that is the best example, right? So for transitioning, starting from money is very important. In the transitioning, the Global Fund has prepared quite well countries, our countries, and all countries have transition plans. Most of them, almost all of them, have money allocated for next years for co-financing or financing. Many of countries already transitioned to financing of first line, and this year and next year they will start co-financing second line. But then the problem comes of the procurement mode, procurement plan, which does not exist in many of countries. So GDF, until now, GDF was the source of procurement for countries because the Global Fund, through the Global Fund financing, procurement was done through the GDF. GDF procurement could be continued for countries. But there are two options. One, that GDF is participating in the local tender, which should be international tender. And the second option, that country signs so-called direct procurement, which is considered like single source procurement for countries. And unfortunately, procurement regulations for countries are not that flexible to allow countries to go for single source procurement. For the local tenders, sometimes the local tender is international. And even if country indicates that they want to procure either WHO pre-qualified or drugs that are approved by stringent regulatory authorities, it is still a problem because most of our countries do not have registered quality assured drugs. I will say that unfortunately we do not have representative of that country, which is Turkmenistan. In the region, only Turkmenistan has registered all drugs. The rest of countries, starting from my home country, Georgia, ending with Kyrgyzstan, only few drugs, and sometimes none of quality assured drugs. First and second line are not registered. So this is a big challenge for procuring locally. Then the problem is that new medicines and repurposed medicines are not registered in countries. This is one thing, which I already mentioned. Second issue, that they are not included in the national essential medicines lists. Fortunately, all guidelines in all countries are revised and they are included in the national guidelines. So, why I'm saying that? Our regulations, procurement regulations and procurement law allows us to procure, our region, to procure only those drugs which are included in the national guidelines, which are registered and which are included in the national medicines list. So these are three prerequisites that should be done. Should be done, that is recommended to have in countries. So countries are not ready for that. Then the problem comes that donors frequently, this is for first line, where we are transitioning for financing. For co-financing, for me, it seems even more complicated because starting from this year for some countries and starting from next year for some countries, the national TB program should co-finance 20, 40, etc. % of SLD, second line drugs, while the Global Fund will finance the rest. But donor will not appreciate or promote using mixture of quality assured and non-quality assured drugs. So what happens, we are going back to early, 10 years ago, when we had cohorts of patients treated by different quality medicines, which is not good. Countries do not have institutions to conduct quality sound procurement. So these institutions need to be built during this transition period. Countries also need to have locally procured quality assured medicines to have them combined with the Global Fund financed medicines. And beyond that, which is the wide problem, we come to the problems that we have for quantification and forecasting, which is also very important for countries. And I explain why. 10 years ago, we had only problem of understocks. Why? Because we just needed money and quantification for a few medicines for the cohort of patients and standard treatment regimens. Now we have extremely high number of individual treatment regimens, which is good because we have new tools, we have diagnostics, new regimens, new drugs, but for quantification purposes and for forecasting, that's a nightmare. TB information systems are not well functional in some countries. So there is no information, patient-related data to be extracted and to be aggregated for quantification. So many countries do very well, especially in the Central Asia, but all is done paper-based, which is extremely difficult. Logistics management information system more or less is organized, but still it is paper-based. So quantification and forecasting is very important, and especially countries, I don't like this word to say, should not, but it is like should not make cohort-based procurement because it may lead to overstock, finally leading to wastage, and finally leading to understock. So we highly promote to make short, frequent procurement schedule at least twice a year. But this refers mainly to GDF procurement. For state, it is again a problem because state normally promotes to pay once a year, and there is no way that you pay twice a year. For the price, Price also is very important. GDF can provide everything, whatever is needed for tuberculosis diagnosis, treatment, prevention, and also GDF provides technical assistance through the headquarters and through the well-trained consultants. So for medicines, we have all medicines, absolutely all. For latent TB, for sensitive TB, for resistant TB, including new drugs. Prices are really very low. I think 90% of audience knows GDF procurement well and knows how much it costs per regimen. If you compare to international prices, if you procure through the tender, it is much lower. Sometimes it comes to 10 times lower than normally. For the new medicines, bedaquiline, as you know, is provided through the donations thanks to USAID government, and it will last until 2019. It is provided free of charge to all patients who are in need in our region. Delamanid also has good price, $1,700 per 6 months treatment regimen, while if you procure it on the market, it is around $3,000 US. As Barbara mentioned, linezolid and clofazimine, we have very low price starting. One tablet costed around $48 US, while now we have it below $1. So price is very good, I mean very low. Even rifampicin, which is now not used that widely, which is medicine for latent tuberculosis, and normally even in USA it is very expensive, so we have it at a very low price. So GDF has quality assured medicines with the very low price. And why? Because we conduct pooled procurement. We procure medicines based on the tender that is announced worldwide, and we supply medicines worldwide to all countries. So our procurement quantity is very high, therefore manufacturers provide very low price. While the same manufacturers in our countries, the market is very small, provide higher prices, and frequently they are not even interested to participate in the tenders, and they are not interested to register their drugs. However, for registration, please, just go ahead with the registration, I mean the NTPs or the principal recipients, because we from our side push manufacturers, and they have to provide dossier, and they have to pay registration fees because they are, they have this condition from our side. So registration is just, the wheel of the national TB programs. Just very recently, KNCV in Kyrgyzstan hired a local company who will be responsible for registration, because registration also is a big hassle to focal person needed, translation of all documents, then the local drug agency is not happy with the paper, so it is a lengthy procedure, so we need to start as soon as possible. First line and second line, and also for preventive therapy. So actually that's it. If you have, I think I answered your question. Thank you.
У меня Майя, можно? Вот, уважаемая Майя, у меня вот вопрос из вашего выступления, очень важный, интересный. Мы столкнулись с проблемой, когда в прошлом году у нас были деньги и был объявлен тендер, но тендер не состоялся, не было поставщиков. И здесь, когда вы обозначили, что GDF может выступать на местных тендерах, я думаю, что этот механизм мы также могли бы у нас в Кыргызстане использовать. Когда на национальные средства, это несложная процедура, GDF только должен на электронном портале закупок зарегистрироваться. Это не очень сложно, ну, минут 10-15 зарегистрироваться на портале и участие в тендере, который объявляется у нас национальным центром фтизиатрии. И я думаю, мы могли бы вот прошлогодние наши проблемы таким вот образом решить.
Спасибо большое. Я абсолютно согласна. Есть одно но, не но, а condition. So, tender document should be prepared in a way that GDF could participate. Like in Ukraine, we were not able to participate because Ukrainian law of procurement and tender documents requested to have representation in country, while we do not have. То есть, если документация, тендерная документация сделана в таком виде, что international supplier can participate, then indeed we are ready to participate.
Well, this is a technical matter. If there's an opportunity to participate in the local tenders, then these procedural issues pertaining to the preparation of technical specifications, you know, there is this capacity, there is this potential of the National TB Center, which needs to be improved, and quite naturally these regulatory documents and procedures have to be updated and modernized. But this does create opportunities to create and to resolve problems. And in 2018, as we progress to 2019, I think this path. Stalbek, Kyrgyzstan. Thank you for the presentation. My question is for Aram Manukyan. You have already optimized your TB services in Armenia. You have reduced the number of labs, the number of offices, but I suppose you probably had to cut down staff, right, to lay off staff. So after the layoffs, did the Ministry of Health or the government offer them any support? For instance, pulmonologists probably needed requalification, retraining, right? Thank you. Well, let's start with the following. Not a single doctor has been laid off yet. Not a single doctor has been left without a job. When we had the first round of reforms, the number of offices went up, and we didn't have enough pulmonologists in our country. And family doctors took some of the responsibilities. So there's family doctors, pediatricians, etc. So they would simply work half-time in these offices, sometimes more than half-time. Then they went back to their areas, and pulmonologists were left there. But now this personnel will move to the revamped Yerevan TB Center, which is now being transformed into pulmonology and TB care center. So the doctors from these TB offices will be retrained, and they will move to this center. This center used to be like half outpatient, half hospital, more of a hospital really, but now it will be more of an outpatient center that will be dealing with all the patients in one city, Yerevan. So all the doctors will simply be transferred there. Well, some will retire. Those that have to retire will retire. Any questions?
Like wrap up. So first, sorry to say that, but still we need donors, I think, in the region. While we, yes, I mean.
Can I ask you a question?
Yes, please.
So I don't know, in terms of the WHO pre-qualification process, I mean, seems like this to be a major bottleneck. So if you can comment on that process and any ideas in terms of also developing national capacities in the region, so that we have more WHO pre-qualified manufacturers of these drugs.
Thank you so much. That is a very good point. In the region, we have good manufacturers and quite a big number of TB medicines manufactured in the region. Indeed, they have good quality. Nobody is arguing that, but they do not have passed WHO pre-qualification assessment. So therefore, they are very highly encouraged to submit their dossiers and to work for WHO pre-qualification. And USAID has very good program funded by USAID, which is under US Pharmacopoeia. This is PQM project, Procurement of Quality Assured Medicines, and that is already working in Kazakhstan and in Uzbekistan, and in Kazakhstan we even expect one manufacturer next year who will submit full dossier for levofloxacin for WHO pre-qualification, and preliminary I cannot say anything, but we expect that by 2019 the pre-qualification will come. So to be on the safe side, for the national TB programs and for countries, WHO highly encourages local manufacturers to submit dossiers to work on the WHO pre-qualification process, because manufacturers, even though we have high number of manufacturers and we have high number of medicines produced in this region, not many countries have that. There are few countries. So if WHO pre-qualification is available in the region, then there is no need to look for other medicines outside the region. So market could be quite big for the manufacturers. But this is not easy process. So this is quite difficult, quite time-consuming, and it requires resources, and indeed, it is a quality process. So this is also a big issue that should be addressed by, but this is beyond the national TB programs. This is the local private manufacturers who should be encouraged by local ministries of health and supported. So everyone wants to have coffee, including me. So as a wrap up, so first of all, what we know that we had huge support from the Global Fund. Huge support. No, I will start from USAID, because major portion of Global Fund financing is USAID. Lots of institutions, lots of systems were created during the last decade. Sustainability of sound TB programs is established. Maybe there are some imperfections that still need to be addressed, but this is the era of very interesting. We live in a very interesting era of tuberculosis, because we have so many new tools that are coming in the market in our life. So transitioning is very important, what we learned today. So about registration, about technical issues, we already talked. So what we need next 3 years to have prepared to bring money from home, yes? But still we need donor help. This is just my opinion, but I think everybody will agree with me. Thank you so much, and thank you presenters for your best presentations.